Thank you for joining us for the third annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Ed Hickey, and I'm Vice President of AAKP and Chair of the Veterans Health Initiative. I'm a former Marine and attorney practicing in Los Angeles, California, and a chronic kidney disease patient whose treatment and prognosis are going very well. Being part of AAKP and chair of the Veterans Health Initiative allows me to make sure that veterans and kidney patients generally are getting the best possible care. We at AAKP interact with decision makers to ensure that any legislation or any regulation that is passed has the patient's voice represented. We're often the only voice at the table when decisions are being made, and it's critical that the patient voice is heard. We've made significant progress over the last few years, and we hope to continue that progress in the future. Today, I'm pleased to introduce Dr. Kenar Jhaveri, Professor of Medicine, Associate Chief Nephrology Director, the Glomerular Disease Center at Northwell Health, Donald and Barbara Zucker School of Medicine, for our session on COVID-19 generation and implications for future kidney patients with acute kidney injury. Dr. Jhaveri, please take it away.
Hi, I'm Kenar Jhaveri, and thanks AAKP and the GEW for this talk on COVID-19 and acute kidney injury 2020 to 2021. These are my disclosures. This is just a consultant for Aztec Pharmaceuticals, Natera, and paid for UpToDate. So I will start with a case, and throughout this presentation, this case will go over AKI and the causes and so forth. So this is a real case of a 70-year-old male presenting with acute shortness of breath, cough, and diagnosed quickly with COVID-19. The patient has a history of diabetes, hypertension, and coronary disease. Initial labs show leukopenia, thrombocytopenia, and a creatinine of 0.8. Oxygen therapy is started and IV fluids are initiated. Quickly, the patient's respiratory status worsens, requiring intubation. In 48 hours, the serum creatinine rose to 3 milligrams per deciliter, and urine output has declined. So let's talk first about the incidence and the risk factors associated with COVID-19 AKI. If you look in the early literature in December all the way to January 2020, there were reports of COVID being a multi-system disease. But the early reports from China suggested a very low impact on acute kidney injury, very low compared to what we started seeing in New York. It was around 2.9 to maybe max 7% in the early 2020 publications. This is sort of a snapshot of the incidence of AKI in hospitalized patients that were available at that time. In Seattle, people were noticing in early 2020 of 19%. Italy was 28%, and that was roaring in February of 2020. China had just reported 0.5%. But what we were seeing, we were almost sure that it was close to 30%, or close to what Italy was seeing when the pandemic hit New York in March of 2020. So first I'll present some of the AKI data from my center and then other large centers within the US and the world. So during the pandemic, when it hit in the center of New York City, our health system, which is around 13 hospitals, we were able to decode what exactly was happening with these patients in terms of kidney injury, timing, risk factors, and its relationship to respiratory failure. And this was one of the first publications published on this in Kidney International in early May of 2020. So this was a retrospective study of 13 hospitals in New York and all COVID positive patients. We were able to study over 5,000 patients at that time. And this was from March 1st to April 5th. And we found the incidence of AKI was close to 47% for stage 1, 22% for stage 2, and 31% for stage 3, but a mean of 37%. And the risk factors were older age, black race, hypertension, diabetes, and vasopressin use, and this whole concept of ventilation. At that time, we were not able to comment much on outcomes because patients were still admitted to the hospital. Later on, we were able to comment a little bit more on those patients, and we found that the true incidence of AKI was around, between 30 to 40%. The AKI requiring kidney replacement therapy was around 7%. AKI that did not require kidney replacement therapy was around 32% per 1,000 patient days, and like I said, 6 to 7% for kidney replacement therapy requiring AKI. So what about the worst of the world? What people were seeing was very varied, from 0.5 to 39% worldwide, but it was most common in the critically ill patients. So in general, and these are all the studies published in terms of incidence listed of them below, AKI was around 22 to 39%. The incidence requiring renal replacement therapy was around 7 to 11%. ICU AKI was around 35 to 70%, and then 22% for AKI with renal replacement in the ICU. Why is there a difference in the occurrence of AKI? It could be a case mix problem, it could be a geographic location problem, or it could be an illness severity and what people saw in different parts of the world. And this is very fascinating. What we noticed was the timing of AKI. If you look here, the density of AKI patients was most of the time closest to the time of intubation. And look at that beautiful curve that we found. It was only happening peri, post, or during intubation was the most of the AKI cases. This is again taking the same concept. 90% of patients requiring mechanical ventilation had AKI, and 97% that required dialysis were also intubated. So this whole connection between intubation and renal dysfunction. And again, another study that looked at AKI in the ICU, this was a multi-center study from the entire US of almost over 30 centers, found the same thing, that the AKI incidence was the most as you actually increase time in the ICU and intubation. What about the ICU patients in AKI? So this is a study again from another center in New York that showed that the smaller study on 300 patients, but they found again that the patients that required ICU stay had a significant high incidence of AKI, and 50.8% that required dialysis, and the mortality was 70%, and a hospital mortality of 66.5%. So this was another similar finding in terms of intubation, ICU stay, and AKI. And this is a multi-center study called the Stop COVID. It was collection of data from all around the country in the United States of over 3,000 critically ill patients with COVID. What was good about the study was it was very detailed data from charts that were extracted. And 67 hospitals across the United States also found a 21% rate of AKI requiring dialysis, and a very high mortality that was found in this case as well. So when you look at all the risk factors for AKI, this is what I could pull together in terms of different types of risk factors. And I'm not going to read them out to you. It's pretty obvious, some of the ones, based on what we have heard in the news and the literature. But some of the interesting ones were the high BMI, the male gender, which is becoming more and more prominent in terms of even severity of COVID, and in the risk factors for admission, the viral load and the elevated D-dimer, ferritin, and CRP, and the hospitalization, certain nephrotoxins that were given at that time that we thought might be helpful in terms of treating the AKI. And then, we were not sure what's going to happen the next wave, what's going to happen with the incidence of AKI. And just like the previous pandemic, the waves happened, there were really three waves, but two big ones. And what's the incidence in the second wave for COVID-19 or the third wave? And that is yet to be seen. So, when at least in the New York, in the European world, we had seen a big push of this COVID wave in March through April that really saw very high incidence of AKI. In the second wave in December through February of 2021, while there were cases of patients being intubated and so forth, there was less AKI compared to the previous wave. The postulated theories could be the viral load, people are masking more, better therapeutics, more organized chaos compared to the first wave when people were just kind of all over the place, different doctors treating different things. And maybe it's the mutation of the virus itself. So in summary, thus far, male sex, African American race, age greater than 50 were the highest risk of AKI. Higher rates of AKI and renal replacement therapy were seen with patients with COVID in the ICU especially, and vented patients was the timing of AKI. AKI developed in 90% of patients on mechanical ventilation compared to 22% on non-vented patients. And finally, patients with AKI had higher levels of D-dimer, ferritin, LDH, procalcitonin, and so forth. So our patient then has a urine sodium of less than 25, a protein creatinine ratio of 2.5. Diuretic challenge has failed. Patients do have noticed this high ferritin, D-dimer, downtrending platelets, worsening anemia. The ICU team says we're concerned about a thrombotic process related to COVID. Could this AKI be a form of thrombotic microangiopathy? Can you do a kidney biopsy? So what is the pathophysiology and the pathology of COVID-associated kidney injury? So as you know, the virus enters through to the cells via the ACE2 receptor, but ACE2 receptors are also present in the proximal and distal tubule. And is there a way the virus can enter the kidney and cause havoc as such as listed here through ATN and some glomerular diseases? So let's talk a little bit about that in the next few slides. So as you know, the patients present with high fever, shortness of breath, and at least one gastrointestinal symptom in 10% of the patients. And as you know, that can lead to pre-renal acute kidney injury, which was probably the most common AKI cause we saw. Yes, and this is a slide that kind of shows you that 66% of the urinalysis that we tested in our paper had a urine sodium less than 35, suggesting that a lot of the AKI was pre-renal. Then let's look at the pathologies that's been reported with various biopsy findings with COVID. So let's start first with the tubular injury. And as you can tell, tubular injury is not uncommon with COVID. We saw that as the most common kidney biopsy finding with COVID-19 infection. And this was partly due to just the septic nature of the disease, the high hemophagocytic nature of the disease, high cytokine release nature of the disease. In addition, treatment of patients with high doses of vitamin C led to oxalate nephropathy, and in some cases, the disease caused rhabdo causing myoglobulin cast nephropathy. So this is another paper from New Orleans in the United States that also found similar findings as us. They were not biopsied here, but they found similar findings based on urinalysis of what they thought might have caused the kidney issue. So these are sort of urinalysis findings from their paper showing that ATN with waxy, granular, muddy brown cast was the most common finding in most of the urine studies. And multiple studies, including from our center, Columbia, Hopkins, a couple other places from Europe, all suggesting that tubular injury was the most common finding both in kidney biopsies and autopsies of the kidney, with patients with COVID-19. So the cytokine storm that we saw with sepsis and ARDS can lead to ATN, high interferon levels, interleukin levels, and this bidirectional approach of the lung and the kidney, leading to this pulmonary upregulation of IL-6 probably caused the ATN and tubular injury. The other things to keep in mind is the protracted volume depleted state, the overall circulatory collapse, and maybe a chronic acute cardiorenal syndrome that led to eventual ATN as well. Let's move on to the more interesting and fascinating things we saw in terms of the glomerular diseases with COVID-19, starting from collapsing glomerulopathy, which was the most common kidney biopsy finding in most series reported. This is a pathology finding of a collapsing glomerulopathy that was seen in patients with COVID. This, we think, is a second hit phenomenon. Most of these patients had an APOA1 gene mutation. You can see here that it is the same concept like we would see in HIV patients, in HDLV patients, and patients who have seen collapsing glomerulopathy. It is exactly the same pathology that was seen in kidney biopsies of glomerular findings with COVID-19. And this is a literature, a collection of all the cases that I looked at that were published related to COVID glomerulopathy. And there were 40 cases at the time when I looked, proteinuria with or without AKI, and 98% of these patients were either of Black race or African in origin. Again, putting the concept of APOA1 gene mutation likely to be the first hit and COVID as the second hit. Here, as you can tell, the similar thing to add to our list of cases that cause collapsing GN from parvo, HIV, CMV, HDLV, EBV. Now we have to add SARS-CoV-2 as well. So 40 cases of CG, 22 had APOA1 polymorphism mentioned because they were tested, others were not tested. And you can see a lot of them had homozygous G1, G2, and 3 with homozygous G2, G2, and 5 with heterozygous. And this is, just telling us another story and adding to the whole concept of collapsing glomerulopathy as a second hit disease. It's also possible that the virus leads to interleukin interferon release, and a patient with APOA1 risk variant stimulates a gene expression of the APOA1, leading to podocyte dysregulation injury and eventually collapsing glomerulopathy. And maybe the patients with severe COVID got this and not, or moderate severe COVID and not just mild COVID. The other findings that were noted after collapsing glomerulopathy actually is thrombotic microangiopathy. Now, I just want to mention that the interstitial nephritis is there in the textbooks now and in the literature, but very few cases. I would say just handful and probably drug-induced. It's not a common finding for COVID-19. So this is the first case of COVID-19 associated thrombotic microangiopathy. We had reported this in late March in Kidney International, a patient who eventually died with COVID-19 AKI. We biopsied the patient, had thrombotic microangiopathy with cortical necrosis. We attempted to give eculizumab, but the patient succumbed to the virus. And we think the patient might have had a complement deficiency, and when the test came back, yes, the patient did have a deficiency in C3b, and maybe that's what led to the second hit and activation of the complement cascade causing worsening TMA. And since then, multiple cases have been reported, some with successful treatment with eculizumab and some of just the reporting of thrombotic microangiopathy. ANCA-associated vasculitis has been reported with COVID-19. There were 4 cases so far since this slide, and 9 additional cases of glomerular basement membrane, so anti-GBM disease as well. And again, the concept here is quite unclear, but it's possible the NET traps is what was responsible for the ANCA disease associated with vasculitis with COVID-19. They do respond, though, well to steroids and rituximab. This is a sort of a big summary of what's been reported, at least on biopsies. On biopsies, ATN is around 9 cases reported, and you can see a lot of them are still alive, but a good amount of them did require dialysis. In collapsing glomerulopathy with ATN, there were 28 cases reported, and almost like 2/3 of them required dialysis, and most of them are alive. Thrombotic microangiopathy is worse. A lot of them require dialysis, and 50% of them actually succumbed to mortality. What also I want to tell you is there are cases reported of renal infarction with COVID-19, and this is sort of pictures of that from recent case reports in AJKD. But the question comes up, is the virus inside the kidney, or is it just an effect of the disease? So as I mentioned earlier, the virus can enter the kidney, enter the cell in the lung and other places through the ACE2 receptor. But the ACE2 receptor is also present in the kidney. So there was a school of thought that it could enter the kidney through the proximal tubule. So this was concerning to a lot of people initially. So in the initial studies by Su et al. From China of autopsies of around, I think, 9 patients or so in Kidney International, there were these structures that were noted in the electron microscopy that were labeled as viral particles. And as you can see, those arrows pointing at those structures that were noted in the electron microscopy findings, especially on the left there, on the extreme right, on the left panel, that actually is what was reported as a viral particle. Since then, Kissling et al. And Farkarsh et al. Also reported similar findings in electron microscopy. Keep in mind, these were not stained with immunohistochemistry for SARS-CoV-2, or disputed by many in autopsy studies and many other studies of biopsies where the immunohistochemistry was done. They were negative for the virus, but were told that these bodies or structures that were found were just multivesicular bodies that can be mistaken as a viral particle. That's on the right. So this is the NEJM paper by Puelis from Germany, showing that in the renal compartment of autopsies, there was viral load replication noted in the kidney. So this was something they had found. And here you can see again that in the kidney, there was copies per cell of RNA of the virus in some of those patients. So there was concern that the virus is actually going inside the kidney, and that's what's causing the ATN or the glomerulopathy. But I think I'm in the side that believes that the virus is not in the kidney, and I think the data supports that more, that these high definition EM findings are just multivesicular bodies. And when you actually stain in large autopsy series from New York and Europe and other parts of the United States, these were negative for immunohistochemistry for the virus, negative. And the virus is likely not in the kidney. So here is another high power field showing again that, am I the coronavirus? In the top is the Su et al. Picture, and the bottom is actually a picture of the membrane vesicular bodies. They look the same. They look very similar. These are just, lysosomal infoldings and vesicles of multivesicular bodies that are formed in the cytoplasm. This is not a virus. It's just a reflection of the disease. And podocytes can endocytose, form these microvesicles, and they can look like coronaviruses or any other viruses. Papers from elsewhere also found these viruses, these sort of bodies, in patients with lupus or IgA nephropathy from many years ago. So this is not anything to do with the virus. The virus does not enter the kidney and cause havoc. It is the disease that causes ATN, and just the sequelae of being sick that leads to the ATN. And again, this is to confirm of all autopsy patients series that were reported from multiple papers, negative detection of virus using immunohistochemistry and in situ hybridization, this gold standard for detecting a virus in any tissue. This is again all autopsy data of kidney related to COVID-19 from various parts of the world, again showing that the most common finding highlighted in black there is ATN, and the virus was not found in majority of the tested tissue. So again, suggesting this is all sequelae of the disease, not the virus entering the kidney. So virus is in the kidney or not, although direct viral infection is possible. Most kidney biopsy studies and autopsies did not find this as a common finding. So COVID virus detected uncommonly by immunohistochemistry in situ hybridization. The EM detection is not optimal method. It solely relies on morphology and particle size, leaving room for a lot of confusion. So in summary, in terms of pathology, the virus can obviously lead to pre-renal azotemia, but the most common finding is ATN from circulatory grafts, rhabdomyolysis, hypercoagulable microangiopathy can be seen. You can get a collapsing glomerulopathy with 2 APOL risk variants, And then rarely you can see this ANCA vasculitis, membranous minimal change, but I think those are just incidental findings. Medication induced is also something we saw. Viral infection directly should be just taken away at this point, a year later since the pandemic. So, summary thus far, that there are a lot of risk factors and medications that can cause AKI. The most common kidney injury is ATN. Collapsing glomerulopathy is the pathology seen in glomerulus as the most common, with a high risk APOA1 polymorphism. Other glomerular pathology associated with COVID-19 may be coincidental or a second hit. It is unclear at this point if SARS-CoV-2 directly infects the kidney. So let's go back to our case. The patient had a kidney biopsy, was started on dialysis, and the biopsy confirmed acute tubular necrosis or acute tubular injury. Is there an association of viral load at admission with acute kidney injury? So this one study from Mount Sinai suggests yes. And if you look down below, the COVID-19 with AKI versus no AKI, the viral load was much higher and statistically significant. Here showing that not only was it statistically significant in terms of AKI, but also is significant in terms of mortality. So the higher the viral load, the higher the mortality and AKI. What about the outcomes? And we'll end with that. So this is sort of a follow-up study from our initial study of the incidence. The reason we could not report outcomes initially in March and April of 2020 is because we didn't have enough follow-up time until majority of the patients were discharged. But once the patients were discharged, we were able to then see what happened to them, what percent of them died, and how many of them required dialysis. I can safely say now that patients that required AKI requiring dialysis had a very, very, very high mortality, and we'll go through that in a little bit. If you look at this slide, it's very telling. The mortality with no AKI at that time in the first wave was 7.3% at our health system of 13 hospitals in New York of over 10,000 patients. When you have AKI that does not require dialysis, the mortality jumps to 46.7%. When you require dialysis, it jumps to almost 80%. This is devastating. Here is the hazard risk of, unadjusted. Look at that in terms of AKI requiring dialysis is 11.3 of hazard ratio. When you adjust it, 6.4% there. It is 6.4% when you adjust it for demographic, comorbid conditions, illness severity, and inflammatory markers. What about the kidney outcomes? What happens to the kidney? So what about the kidney injury that did not require dialysis, which was around 83.4%? Like I said, close to 50% of them died, but the ones that survived were 51.7%. Then out of those, 74% actually had good renal recovery. 25.9% had no renal recovery. What about the ones that required dialysis, which were around 16%? Like I said earlier, close to 80% of them died, which is very, very sad. But the ones that survived, 17%, almost 70% of those had good renal recovery. They came off dialysis. So we were doing something right. Providing dialysis was still good for those patients. And yes, we lost 80% of them, but we were able to save 20%. And out of those 20%, a good 70% came off dialysis. That is very, telling us that we have to do the best we can for these patients. This is again telling you the ones that did not recover, around 36 of them that did not recover. At that time when we checked in November, 92% was still on dialysis and 3 came off dialysis. What was the risk of factors that actually kept them still on dialysis? It really came down to having chronic kidney disease. That was the biggest risk factor. 57.6% of them had it. What about the data from other centers in terms of outcomes? So this is the data from Mount Sinai, another sister hospital in New York, around 3,900 or so patients. And again, they found, looking at outcomes, majority of them died. But the ones that require dialysis, again, similar to us, higher mortality, but again, close to 25% of those recovered, and of those, 65% came off dialysis. Very similar findings that to ours. This is the stop COVID data. Remember, I had mentioned earlier about that multi-hospital study from the US. They looked at all the ICU patients with kidney injury and requiring dialysis. Like I said, they also found a similar finding. Of the ones that got discharged, 34 patients that got discharged alive, 66% there were dialysis independent on discharge, and 34% were dialysis dependent on discharge. Again, very similar to the findings we had. This is a study from Europe, a very small study, but it's showing the 90-day outcome, and that is actually important. So as the days progressed, the patients that were on dialysis or had AKI were getting better and better. And you can see here, as day 90 progressed, less and less patients were on dialysis or had acute kidney injury still lingering around. Here is another fascinating two studies, one from Columbia University and the other from Germany. On the left, showing from Columbia that as time progressed, the days since starting dialysis, as time progressed as an outpatient, most of those patients who got discharged recovered or came off dialysis. The light blue bar keeps increasing. And a similar finding in Europe as well, as time progressed, around 150 to 200 days since the start of kidney replacement therapy, the patients were coming off dialysis, which is good. So we were doing the right thing by providing dialysis to them, despite our resources being really pulled. This was the right thing to do, and try to find machines and get them dialysis. So what was the risk factors for mortality with acute kidney injury that required dialysis? Older age, oliguria, admission to a hospital with fewer ICU beds, and that was important, and a greater regional density of COVID, which was happening in the northeast of the United States at that time. And being African American or a black color, unfortunately, was a risk factor for mortality. So the other thing I wanted to just mention is majority of the patients that required dialysis did die after most centers reporting full outcomes, which was really tragic. But the ones that survived, I just can't stress that enough. The rate of renal recovery is very high. In the longest reported so far, 150 days, there are actually good amount of survivors out there who came off dialysis. And I think as the nephrology community, we should be proud of getting these patients out of the hospital and getting them off dialysis. Is there any biomarkers that can predict AKI? Unfortunately not. There is one study that looked at proteinuria as a marker for severe tubular damage. One study had looked at potentially the nephro check as an early marker for kidney replacement therapy and death. And one study that looked at SUPAR as predictive of AKI need for kidney replacement therapy. Very small studies, but something to kind of look out for. If we can predict this, I think that would be more useful. Is AKI in COVID different from other AKI? This is a fascinating study in British Medical Journal that compared COVID-19 to flu in the Veterans Affairs hospital system in the United States, and found that the flu-related AKI was less severe than COVID. So COVID by far had a higher incidence of AKI, more dialysis, more vasopressor use, more PEs, more MIs, and more deaths. There were actually 5 times more death risk with COVID than was with the seasonal flu. So this is not just the flu, guys. This is serious, and this is much more damaging to most of your organs compared to the flu. Another study from Yale, looking at over 22,000 patients, looking at AKI from all causes versus COVID. AKI from COVID had worse outcomes in terms of dialysis, chance of recovery, and again, length of stay and mortality. So this is something that's quite different than other causes of AKI. And I think we need to be appreciative of the severity of this type of disease and this virus. So the key points thus far: AKI was common in hospitalized patients. AKI was associated with high risk of in-hospital death, especially among those requiring kidney replacement therapy. But among patients who were discharged, the recovery was amazing, and a good amount of them recovered. Among those who still required dialysis, majority of them came off and had, history of chronic kidney disease. the effect on the kidney is worse than other forms of AKI from flu or other causes. And in the last 2-3 slides, I'll mention sort of the treatment and surge planning for dialysis. So I just wanted to highlight to you guys here that planning is so important. You can see here, this is our health system of 13 hospitals. In 2019 versus 2020, the number of nephrology consultations during the time of the first wave increased by 39%. The daily hemodialysis treatments increased by 56%, and the renal replacement therapy in the ICU increased in that 1 month period by over 500%. This is huge. This is why there was a supply issue when the demand was so high. So preparation is so key in future waves of COVID. What are the options we have when you have equipment shortages, nursing staff issues? Well, you can do continuous renal replacement therapy, you can do intermittent HD, or you can do prolonged intermittent renal replacement therapy, which we tried, or some centers in New York amazingly did acute peritoneal dialysis that worked well. But we also did something called walk-away SLED, which we learned from the Vanderbilt colleagues, where we did SLED with one dialysis nurse managing around 5 to 6 patients in the medical intensive care unit. So these are a nice paper in C. Jason that talks about different ways we can help and kind of minimize the workload of our nurses, and at the same time provide the best optimal care for our patients, is using SLED with a more walk-away approach, which I just explained, rather than one-on-one nursing. Nursing burnout has to be kept in mind. Physician burnout has to be kept in mind. But at the same time, we have to provide optimal care for our patients. So some of these clever techniques listed in this slide really helped us fight the pandemic, and without any shortages, and cleverly during the time in March, April of 2020. So this is a sort of a wrap-up slide telling us that where we are and where we're heading next. The vaccines right now are really helping cut down the rate of infection, at least in the United States and some parts of the world. Currently, certain parts of the world are really raging with their second or third wave. But the long-term outcomes of these patients who had acute kidney injury is really not known. We still don't know the social determinants of health with these outcomes. We are not sure about the risk factors completely and the pathophysiology and what medications are safe. We're slowly learning that the vaccines are efficacious in our dialysis patients, getting them close to 89% efficacy, but our transplant patients, close to 17 to 20%, they're getting the antibodies. So we're still learning about that and hoping that they don't get infected in the next wave, if we have another wave, and if their booster shots are still needed. So a lot more to learn still about this disease as it keeps unfolding in front of us. And I just want to say a thank you to a few people, Jiang and Jamie Hirsch and Dr. Fishbane from my health system, who were the core research team, including myself, a lot of the work we did. Kathleen Liu from UCSF, Girish Nadkarni from Mount Sinai with some of the slides here, and Shruti Gupta with some of the slides here from Stop COVID lead investigator. But I just want to give a shout out to all my New York colleagues and health system, my own health system, Northwell Health, NYU, Presbyterian, Mount Sinai, and Einstein. I think all the health systems really stepped up and made New York shine and save patients' lives while they were in that pandemic first wave that the world saw in 2020. This is a thank you slide to my colleagues here who I work with. This was the last picture that we took before the pandemic hit in 2019 at a party we were all at with some smiley faces. And the right is now us masked and treating patients, and no vacations. Everybody worked hard and deserved and did their best they could, and I just can't thank all of them. Without them, none of this work could be possible. Without them, none of the patients would have been saved. And I think the nurses and the techs, the dialysis staff, everybody did a phenomenal job. And I would just like to end by dedicating this entire presentation and our work to patients and caregivers during the COVID pandemic that's still ongoing. Thank you.
Thank you, Dr. Jhaveri, for taking your time to share your insights and expertise. We appreciate it very much.